Good morning, Dr. Pettigrew.
Morning, Sir Brian.
Well, obviously you can hear me. You can see me as well?
Yes, I can, thank you.
We can see you very well. Now, let me apologise for the delay there's been this morning, both to you and to those who are watching remotely. In a moment I'll describe the scene so that they know where we are and so that you can understand as well who you're speaking to. But it was an unfortunate delay in making sure that we had the right documents on the system so that you can be asked questions about them. So I'm sorry about that. It shouldn't have happened, but it has. But we're now ready to begin. You're at home, I gather.
That's correct, yes.
And your counsel, Simon Bowie, is elsewhere, I think.
Yes, they're elsewhere. Mm-hmm.
Now, you're talking to a room here in London, in Fleetbank House, where there are, I think, 4 members of the legal team facing me. We have a person whose job, Shumik, whose job it is to make sure that the documents are displayed on the screen. And then we have 3 other members of the inquiry staff, one of whom, Mary, will take the oath or affirmation in a moment or two. You are being watched remotely by probably somewhere in the region of 150 to 200 other people from time to time. It's generally around about 150 during the evidence during the day. So you're talking to them as well as to us. Okay?
Yes, thank you, Sir Brian.
Now, Mary, would you like to take the oath, please?
Please state your full name.
I am Anna Frances Pettigrew.
Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth. Thank you.
Dr. Pettigrew, can you see and hear me?
I can, thank you, and good morning.
Good morning. I'm going to start by asking you just to help us with an overview of your career. I understand from your statement and other materials you provided that you had various house officer jobs at the Royal Hospital for Sick Children in Glasgow in the mid-1970s.
That's correct, 1976 to 77.
And then in early 1977, you took up a post as a senior house officer in Glasgow Royal Infirmary, and you stayed in that post until early 1979, is that right?
Until January. I left probably mid-January 79.
During that time, you had some involvement with the treatment of patients, adult patients with bleeding disorders. How much of your time was spent with bleeding disorder patients and how much with more general haematology or other work?
Well, I wasn't involved in any haematology work, but I was basically a medical SHO in the Department of Medicine at the time, and but I also had a responsibility for helping with the Hemophilia patients. Pardon me. I would say that probably the bulk of my time was spent with general medical patients, and my duties in Hemophilia tended to be after the ward round in the morning when the patients came to get their treatment. I think I explained in my statement that the patients would phone first thing in the morning, and then by the time the ward round finished just about 11, they would be there and I would assist in giving the treatment. Because I don't think the haemophilia sister at that time was able to perform venipunctures. Okay. And then obviously if patients came in during the day, patients with haemophilia came in during the day, I would see them as well. But I was also involved in the on-call rota and what we call acute medical receiving, when the unit was responsible for admitting emergency medical patients.
And during the time that you worked at the Royal Infirmary, who were the consultants to whom you reported insofar as the haemophilia patients are concerned?
It was mainly Dr. Colin Prentice and Professor Forbes. I think Dr. Davidson was a co-director, but I really didn't have anything to do with Dr. Davidson. He tended to deal more with the blood transfusion, blood product side. And Professor Lowe was also, I thought, a registrar, but I think he might have been a lecturer at that stage.
And your statement tells us that at that time at the Royal Infirmary, the main products being used for the treatment of patients with bleeding disorders or with haemophilia were Cryo, Precipitate and NHS factor 8. Is that right?
That's correct. At some commercial factory it was used, but I think that was primarily if there was elective surgery, such as knee joint replacements being carried out. And obviously if patients had an inhibitor, I think it'd be FIBA, the commercial product would be used.
Do you have any recollection as to whether DDAVP was used at the Royal Infirmary at that time?
Well, we started using DDAVP at that time because I think, and you sent me a copy of a letter to the Lancet referring to its use. I think Professor Lowe was interested in, in trying to use DDAVP and to see how effective it was and what side effects it might have.
Did you at that time have any involvement in the decisions as to what treatments to use?
No, absolutely none.
And can you assist us in terms of the kind of routine testing or monitoring that was undertaken for patients at that time at the Royal Infirmary? Were liver function tests undertaken routinely?
Yes, obviously we checked for hepatitis B. Obviously sometimes we check for factor VIII levels inhibitors, pool blood count, and also LFTs. And because I knew that LFTs was part of the routine blood testing, when I was at the Royal, I introduced that at York Hill.
And moving on to York Hill, you joined York Hill in May of 1980, is that correct?
Yes.
And you remained there until February 1989.
Probably end of January 89.
You were part-time. As I understand it, you did 6 sessions a week.
Yes, I did 5 mornings and 1 afternoon. On the Thursday afternoon, we had the general haematology clinic. So I stayed on and assisted at the general haematology clinic on Thursday afternoons.
And you didn't do on-call work?
None at all, no. That was why I worked in the position of clinical assistant, which obviously didn't involve any on-call, and I had no responsibility for decisions, management, procurement, etc.
You've anticipated my next question, which was to ask you what precisely was the role of a clinical assistant as distinct from a registrar or senior house officer or consultant?
Well, first of all, it was not a training post, and it was not a post in which there was professional progression. It was really a post which was more to do with face-to-face, practical, day-to-day clinical care of the patient. It was more hands-on, if you like. And I think that's Dr. Willoughby at that time, I think, created the post and employed me because he was looking for more assistance in dealing with the with treatment for primarily patients with leukemia and what we call solid tumours, children with cancer. And they were attending the day unit for injections of chemotherapy, procedures such as bone marrows, lumbar punctures, and if there was any problems, rather than go to the GP, the children would come to the day ward, and that was what primarily I was involved in.
The consultants under whom you worked at York Hill were initially Dr. Willoughby, then
Yes.
Dr. Han from the beginning of 1983, and then Dr. Gibson from around 1987, 1988. Is that right?
That's correct, yes.
You told the Penrose Inquiry and have told us that this was a post that was funded not by the NHS but by the hospital. What does that mean?
Well, it was actually funded. Dr. Willoughby's department, like a lot of departments involved in treating cancer, were given donations, and he decided to use the departmental funds to fund this post, which, as I say, initially was primarily to assist with the practical treatment of patients with leukemia and what we call solid tumours.
You left in 1989 and retrained as a GP, and from 1990 onwards you practiced as a GP.
Yes, I did my, what we call, in those days we called it your GP training year in 89, 90, and I became a principal in general practice in 1991, February 1991.
And so you haven't worked in haematology as an area of speciality since 1989?
No.
I'm going to start by asking you some questions about the patients, facilities and services at York Hill, and we'll look at a handful of documents, Dr. Pettigrew. Shomik, could we have PRSE 302887, please? Dr. Pettigrew, this is a report that was prepared for the purposes of the Penrose Inquiry. It's just to give us some figures about the numbers of patients. If we could go, please, Shomik, it's probably page 30 on the screen. That's it. So we can see here, Dr. Pettigrew, if we look at it, it's a table headed numbers of patients registered at Scottish Haemophilia Centres, 5-year intervals 1970 to 2011. And we'll just look at the period when you were there. So if we pick it up, if we go to the next page, please. If we pick it up in 1980, we can see Glasgow, RHSC, 55 patients with haemophilia A, 14 with haemophilia B, 1 with von Willebrand disease, giving a total of 70 patients. And then if we look at the table below, which is for 1985, we can see 73 patients with haemophilia A, 20 with haemophilia B, 1 female patient with a factor 8 deficiency, 1 with a factor 9 deficiency, and 13 patients with von Willebrand disease, giving a total number of 108 patients. Does that broadly accord with your recollection?
Yes, I mean, I couldn't have given you a figure for the number of patients who treated, but I think that's, well, obviously that's correct.
Yes, and I think we can see from that that's the number of patients registered, according to UK HCGO data, I anticipate. Do you have a sense of, at all, of approximately how many of those patients were patients with a severe bleeding disorder?
I would think you're probably talking in the region of about 15 to 20, but that is a guess.
Okay, fair enough. Now, obviously, the hospital was concerned with the care of children. At what age typically did a patient cease to be the responsibility of York Hill and transfer to the care of the Royal Infirmary in Glasgow?
Well, as I referred to this in my statement, oral evidence, the Penrose Inquiry, it really depended on the individual. I think at that time in York Hill, officially, children were admitted up to, I think it was either 12 3/4 age. But obviously children with a chronic condition could be maintained at York Hill for longer. It tended to, the other thing is, if children were admitted to York Hill, there was educational facilities, which of course there wouldn't be in an adult unit. So we tended to keep the boys at York Hill until they were about maybe 15 or 16, and then transfer them to the Royal Infirmary. And a lot would depend, you know, if they were very mature, pardon me, they might have been transferred at 15 or, but if they were immature, we might have held on to them till they were 16 or possibly even 17.
Show me, we can take the document down, thank you. Now, York Hill's responsibility wasn't limited to Glasgow alone. It essentially provided a service for the whole of Western Scotland, is that right?
Yes, you know, I remember we even had a patient who had to come sometimes from one of the Western Isles, and Ayrshire, South Ayrshire. I can't recall, I heard Professor Ludlam talk about the borders, and I don't recall any patients from Dumfries, but certainly the rest of the west of Scotland, and we might have covered Dumfries, we might just not have had any children with haemophilia there.
What about Galloway? Would that go with Dumfries?
Yes, Dumfries and Galloway would go together, and I think, well, I think strictly speaking they're under the west of Scotland, but I think there was a crossover between Edinburgh and Glasgow with that area. Certainly, children with leukemia, we had children from Dumfries and Galloway.
How did York Hill manage the relationship with other smaller hospitals or non-specialist hospitals that might be the first port of call for such patients? Were there any systems or protocols in place?
I don't think there was any systems or protocols in place, but I think most haematologists, certainly those who were in the Greater Glasgow area, would send their patients with haemophilia to York Hill. Obviously, somewhere like the islands, it was a bit different. And if I can't remember, but I don't think there was anybody with a patient with severe haemophilia in the islands. But obviously, if somebody in the islands needed treatment, they would have to be flown down. And I think that's what tended to happen.
To what extent at York Hill did the service operate autonomously? Did it set its own policies, or did it look to the Royal Infirmary or elsewhere for guidance?
I think Professor Willoughby was an autonomous practitioner. Dr. Han, I think, was more. There was more of communication with the Royal Infirmary, I think, after Dr. Han, and certainly after with Dr. Gibson. But Dr. Willoughby was autonomous.
Did you, during the time when Dr. Willoughby was consultant, did you have meetings with the Dr. Lowe or any others from the Royal Infirmary to discuss patients or policies?
No formal meetings. I have to say that Professor Lowe's wife is a good friend of mine, and Professor Lowe, I've been in contact with Professor Lowe, all these years, and sometimes he would keep me up to date with what was happening in the Royal Infirmary and perhaps what they were introducing, and that sort of thing. Not really any discussions about patients.
In terms of the facilities at York Hill, when you were first working there in the early part of the 1980s, your evidence suggests that there wasn't really a haemophilia centre as such. Could you describe to us physically what facilities there were for patients with bleeding disorders and how and where they would be seen typically?
Yes, all the haematology patients who required treatment or procedures would come to the daybed area, and the daybed area was a ward that basically was a facility used by all specialties in the hospital. And it consisted of 4-bedded areas, a waiting room, and 2 treatment rooms, one of which was slightly larger than the other and might have been considered as a small minor surgery theatre. There was a small treatment room, and the haematology department tended to use that small treatment room, and one of the bedded areas tended to be used by the haematology patients. There was a haematology sister, I think it was Sister Wright, and then Sister Murphy came in 1983. And we worked closely with the dental department. So there was the patients with haemophilia were encouraged and I think given appointments to come and see the dentist on a fairly regular basis in the hospital. It was Mrs. Dunn at that time, and I can't remember who succeeded her. And also there was close liaison with the orthopaedic surgeons. So during the day, well, initially when I started at York Hill, and I think before, apart from the patients who were regular attenders, the regular attenders would tend to come straight to the daybed area because obviously the haemophilia sister was there. Other patients might go to casualty first of all, and out of hours they would go to casualty as well. Pardon me.
And the evidence that you gave to the Penrose inquiry would suggest that prior to Professor Hand's arrival, there wasn't a regular clinic for bleeding disorder patients. Is that right?
There wasn't. And I remember after Dr. Han arrived, I remember Professor Lowe telling me that they were having regular clinics, and I discussed it with Dr. Han, and he agreed wholeheartedly that we should start having these regular clinics, and he managed to organise it with the hospital management and obtain a room in the outpatient department, initially once a month, but we increased the frequency as time went on.
And in your oral evidence to the Penrose inquiry, you described it prior to those new arrangements after Dr. Hand's arrival, that children weren't really reviewed, but they came in as and when that they needed to. Is that correct?
That's correct.
At some point, I think again your oral evidence to the Penrose inquiry puts it possibly 1984, 1985, there were some new facilities for the centre or for the service, a move towards 7A, is that correct?
Actually, I think it was a bit later. I think it was about 87. And the haematology unit was given a whole ward, and the haemophilia was given a room at the end of the ward. It used to be, I remember when I worked as a JHO in York Hill, it was a laboratory room. So we were given that room, and it was just inside the door of the ward, so it was quite easy for the parents and the patients to come in to see us there.
Between 1980 and 1983, what other medical staff would have been involved with the care of patients with bleeding disorders, other than your role, Dr. Willoughby's? Were there other doctors, registrars, SHOs involved?
There was usually either an SHO or a registrar who was rotating through York Hill for possibly 6 months from adult haematology as part of their training. And Dr. Willoughby also had a full-time leukemia research fellow. He also had, there was, I think, 3 of us part-time. There was Dr. Anne Campbell, who probably left about 1984. And she, like me, was a clinical assistant. And there was a Dr. John Kelt, who again was there till about 1984. He was a GP in Stirling and came to the daybed area, I think, 3 mornings a week. And then there was myself.
It sounds as though the service that you're describing, Dr. Pettigrew, was predominantly a cancer service that also looked after patients with bleeding disorders. Is that a fair way of viewing it?
I think it is, and certainly the bulk of my involvement was not with patients with bleeding disorders, certainly until after Dr. Han came.
We've heard, and you may have, if you followed the evidence of Professor Ludlam, heard it last week, that Glasgow Royal Infirmary and Edinburgh Royal Infirmary effectively had a status equivalent to haemophilia reference centres. Do you know whether the service at York Hill had any particular status or was characterised in any particular way?
Well, I wasn't really aware at the time of any particular character. And I noticed in Dr. Willoughby's statement to the Penrose Inquiry that he insisted that we were never a haemophilia centre.
Did you have any involvement with the submitting of annual returns to Oxford for the patients at York Hill?
Well, in actual fact, no, I didn't. And as I have been listening to the evidence given by clinicians, the thought occurred to me, did we send returns? Who did it? And I think it must have been, it was possibly the chief technician in the lab that did it. But, I don't really know who did it, but certainly I wasn't involved.
The chief technician in the lab, is that Mr. Jewell? Or is that...
Mr. Jewell initially, and then he was replaced by Robert. I can't remember his second name, sorry, and I should, but I can't remember.
So in terms of proportion of time spent on the care of patients with cancers and patients with bleeding disorders, approximately how much of your time do you think, or what proportion of your time was spent on the care of the children with bleeding disorders, and what proportion spent on other disciplines?
Well, initially, it would have been probably 90% in non-bleeding disorders. And I think, as I said in my statement, as time went on, and I think as the parents and the patients got to know me, and some of the parents had brothers that I had known in the Royal Infirmary, I think as time went on, I became more involved with the parents and the patients as they came to the daybed area. And after Dr. Han arrived, again, my involvement increased. By the time I left, I would say it was probably maybe 50-60% bleeding disorders and maybe 40%. That's a very rough figure, really.
What proportion of Dr. Willoughby's time was spent on the treatment of patients with the children with bleeding disorders, and what proportion spent on cancers or other areas?
Well, I think the majority of Dr. Willoughby's time would have been spent, but remember, he was responsible for running the lab. He was responsible for haematology problems that arose in the maternity unit, which was attached. He was responsible for the treatment of all patients with hematological malignancies. And at that time, he also dealt with a lot of patients who had what we call solid tumours, other cancers in children, so as well as bleeding disorders. And I think, as I say, when I arrived, he'd set up his home therapy programme, and I think he had established most of the boys who had a severe degree of haemophilia on that home therapy programme. So when I arrived, there was really only those patients with severe haemophilia who were younger and who weren't on the home therapy, and patients who were less severely affected and von Willebrands that were coming to the daybed area. So the majority of his time was definitely spent with patients with other haematological patients.
And the way you put it in your evidence to the Penrose Inquiry was that Dr. Willoughby was running multiple services.
Absolutely, yes. I think Dr. Han was quite, I don't know if surprised, he obviously knew, the job that he was coming to, but I think he stated in his evidence that it was one of the most underfunded and probably understaffed. I think there's about 6 haematology, I couldn't give, Dr. Gibson can give you a better figure, but, there's that sort of number of consultants now at York Hill. I should add at some point, I think, but was probably after Dr. Han arrived, there was a consultant oncologist appointed. And both in Dr. Willoughby's time and Dr. Han's time, there was close cooperation, and with a radiotherapist oncologist at the Western Infirmary as well, who dealt with the radiotherapy treatment of the patients with leukemia.
How often would you discuss issues relating to the care of patients with bleeding disorders with Dr. Willoughby?
I think if there was any, pardon me, if there was anything that was other than routine, so if there was any patient who came in, well, the same with all the patients who came to the daybed area. If there was anything that we felt I needed to discuss with Dr. Willoughby, any problems that I felt weren't straightforward or within my remit, I would discuss it with Dr. Willoughby. So
And-
that would go for orders as well.
And again, during the time that you were there, 80 to 82, when Dr. Willoughby was still there, how often and in what kind of circumstances do you recall parents and patients with bleeding disorders actually seeing and being seen by Dr. Willoughby rather than by you?
I think certainly if they were admitted to the ward, they would be seen by Dr. Willoughby, because we all did a ward round in the morning before we started the work in the daybed area. We had a ward round, and we also had a brief meeting in Dr. Willoughby's office before we started, and that was an opportunity to bring up any problems that I had encountered as well. But I don't think that he spoke very often to the parents in the daybed, unless there was a problem. And he'd obviously worked with Sister Wright before I came, and she would be aware of the situations in which Dr. Willoughby's opinion was required as well.
Do you know the extent to which Dr. Willoughby had or sought and obtained advice from others about the care of patients with bleeding disorders?
I can't really say. I know that, and you'll be aware that Dr. Willoughby wrote a textbook on paediatric haematology, which is quite was highly regarded at the time, and he did have a chapter on bleeding disorders with many references. And Dr. Willoughby was the type of clinician that tried to keep abreast of developments. I think you read in his statement about contacting a paediatrician in America about bone marrow transplants, and I think I presume he went to the UK, even though we weren't a haemophilia centre. I think he probably went. I presume he went to some of the UK and Scottish haemophilia directors' meetings as well. But that's as far as I can say regarding that.
Was material produced by UK HCDO, minutes or reports that might be shared at directors' meetings, did that ever get disseminated to you and your more junior colleagues? Sorry, was that a no?
Yes, sorry, no.
The transcriber can't pick up nods and shakes of heads. So. And then, in terms of the impact of York Hill's responsibility for patients across the west of Scotland, in the Penrose report, I'm not proposing to take you to it, Dr. Pettigrew, but there's a description in the Penrose report of the smaller hospitals gravitating gradually towards York Hill. To what extent did that impose a logistical burden or practical burden on the service at York Hill?
I don't think it imposed a burden that was apparent. I mean, those figures you showed me, the numbers between 1970 and 1980, there was obviously quite an increase in the numbers of patients being treated at York Hill, which would obviously represent that gravitation. And I think towards the end of probably 77, maybe 78, Dr. Willoughby had procured the services of a haemophilia nurse. So that would have helped to absorb the extra workload. But I wasn't aware of an impact as such.
Dr. Willoughby left York Hill at the end of 1982.
Yes.
Do you know anything in terms of your own personal knowledge about the circumstances or reasons for his departure?
No, really only what I have read in his statement and Dr. Hand's statement. at the time. I mean, I should have known at the time because I should have remembered that there was that industrial action, and Dr. Willoughby was a very committed, highly professional man who was dedicated to his patients, and I think he found it, obviously must have found it appalling, or to him appalling, that not everybody appeared to have that same dedication as he had.
Did you have any conversations directly yourself that you can recall with Dr. Willoughby about his leaving?
Not that I can recall. I think he just announced that he was leaving. He'd been offered a job in Perth.
I know from your earlier evidence that you yourself weren't involved in out-of-hours on-call care, but how was out-of-hours care arranged for patients with bleeding disorders, to your knowledge?
Out of hours, the paediatric, usually registrar, I think, or maybe initially GHO, but probably registrar, would see the patient in casualty and would contact whoever was on call for haematology. That might be Dr. Willoughby, it might be the rotating registrar, it might have been the leukemia research fellow. And obviously if there was anything that they were felt that was out with their level of knowledge, they would contact Dr. Willoughby.
Now, I'm going to ask you next about the treatment policies at York Hill and the what products were used for the treatment of patients. We'll start by looking at the same document we looked at before, PRSE 302887, please. And if we go, Shomik, I think to page 25, it's page 19 of the internal pagination, Dr. Pettigrew, if you're looking at a hard copy. So we can see here, it's headed Glasgow Royal Hospital for Sick Children, and we've got figures from 1977 onwards of the kind of volumes of products used. Now, I'm going to take you to a different document rather than go through this line by line, Dr. Pettigrew, but I just wanted to put that up so people can see where the next document has come from. If we just go over the page, Shomik, we can see that the data here in this report that was provided to the Penrose Inquiry carries on into 1990 and indeed 1991, which is after you left. Could we then have INQY 40242, please, Shomik? So this is a table that's been prepared. I'm grateful to my colleague Ms. Scott for this, taking the data from the report that we've just looked at. And so we'll use this because it's slightly easier to read. So we can see, if we look first of all at table 1, Dr. Pettigrew, and picking it up from 1980 onwards and looking at the percentages, very little cryoprecipitate is used, and the bulk of the treatment, 99.9%, is with factor VIII concentrates. And it's fair to say, if we just look down the figures all the way through to 1984, 1985, we can see that pattern continues. The vast majority of treatment is with concentrates rather than cryoprecipitate. Is that consistent with your recollection?
Yes. I noticed that the first table that you produced, obviously, there was more cryoprecipitate used until the introduction of home therapy.
Yes.
So in 1977, there was 41,930 units. I don't know what percentage that was. And it appears that concentrate was introduced first in 1977 with more 78, 79, which I think was when Dr. Willoughby was introducing the home therapy. But certainly, and remember that these patients on home therapy were also on prophylactic therapy, so they were using a lot of concentrate.
Yes, and I'm going to come on to the home therapy programme shortly. And then if we just look at table 2, towards the bottom of the page, we can see that in terms of the source of the factor VIII concentrate, in 1979 it's 28% from PFC, so the NHS concentrate, 72% commercial. In 1980 it's 19% NHS, 81% commercial. In 1981, 42% NHS, 58% commercial. In 1982, 51.5% NHS, 48.5% commercial. If we go over the page, please, Seamus, we can then see in 1983, there's a shift, and the majority then, and this is obviously when Dr. Han has arrived, is NHS concentrate with only a small amount, 3% being commercial, and then very little commercial in 1984 and none from 1985 onwards. Again, does that reflect broadly your recollection?
I think it does, yes.
The commercial product from 1979 that was used was, according to the table that we saw in the report presented to the Penrose inquiry, all from Armour. It was the factor VIII product. We can take that down, Jim. Did you ever have any discussions with Dr. Willoughby about why that particular commercial product was chosen?
I didn't have any discussions about that, why that particular product was chosen. I did remember asking him why commercial factor VIII was being used, because I wasn't used to using it in the Royal Infirmary. And his response to me was that when he was starting his home therapy programme, SNBTS could not supply sufficient amounts or reliable amounts for him to provide for his home therapy programme.
Now, were you aware at the time, and did you ever discuss with Dr. Willoughby, if so, the fact that in Edinburgh, the policy was essentially the opposite one, to use SNBTS products and avoid commercial as much as possible?
I would never have I wouldn't have known what the policy was in Edinburgh.
Do you know whether Dr. Willoughby made any attempts to get more SNBTS product?
I can't really answer that, Ms. Richards. I wouldn't know if he had or not. Can I just point out that in the chapter 21 of the final report of the Penrose inquiry, there is a reference, you want me to give you it, to a difficult or a slight shortage of SNBTS 78, 79 and 79, 80. And obviously that would have been the year 79 that Dr. Willoughby had started his home therapy programme.
So was it your impression that ease of access to the product was at least a contributing factor to Dr. Willoughby's use of commercial products? And that having started on commercial products for home therapy, he essentially carried on with that?
Yes, I think it was a reliability of supply. I noticed that in his statement, he also talked about ease of use and other reasons for using it. But I was led to believe by him that his main concern was having a reliable supply for his patients. And the commercial concentrate tended to be used on the patients who were on home therapy, and the NHS for patients who were not.
You're correct that Dr. Willoughby's own statement to the Penrose inquiry emphasised the question of the convenience of the commercial concentrate rather than issues of access or reliability of access. Do you recall him expressing any views to you about the greater convenience of the commercial concentrates and what he meant by that?
I think he probably did, because the product was easier to use. It dissolved more quickly. It was provided in packs which had all the other necessary equipment in it. The cotton wool, the little plasters, I'm not really sure if we may have had the little butterfly needles that we used, but he obviously felt that it was a more convenient product to be used. And you obviously have his statement to the Penrose inquiry regarding his opinion about risks or otherwise.
Dr. Han was plainly able to make the switch to almost entirely and then entirely NSBTS product fairly early in 1983, given what we've seen from the figures that we looked at. Do you know of any reason why Dr. Willoughby couldn't have made that same switch earlier?
Well, I think if I remember when that table was up, there was a reduction in the use of commercial concentrate in 1982 when Dr. Willoughby was there. It was my impression at the time that Scotland was achieving self-sufficiency at that time. I know there's been a lot of discussion about when did Scotland achieve self-sufficiency, and the opinion varied between those in blood transfusion and the clinicians. But it was my impression that Dr. Willoughby was able to access increased supply of NHS concentrate from 1982 because there was a better supply from AFC.
And were you ever party to any discussion or dialogue that Dr. Willoughby might have had with representatives of the Blood Transfusion Service or PFC?
I didn't have anything to do with procurement.
In terms of the actual arrangements for the procurement of the commercial product, did you have any involvement with that?
No, it was through, again, Mr. Jewell, the chief technician, and I wasn't actually aware how it was paid for or anything, but I see from Dr. Willoughby's statement it was ordered through pharmacy.
You've referred in your statement to there being visits from ARMA and indeed other pharmaceutical companies. Were you ever part of any meetings that took place when pharmaceutical representatives of ARMA or other companies visited?
What tended to happen is from time to time the representative from ARMA would come to, I think, to speak to Mr. Jewell, and he would come through the daybed area and basically, sort of say hello to the nurse, the haemophilia sister and myself, and just check, were we having any problems with the product, or that would be the extent of my involvement with them.
Other than the home treatment packs and perhaps the ARMA packs, including the kind of bits and pieces of apparatus that might be required, was there anything else that was funded by ARMA or any other pharmaceutical company in those early 80s?
I mean, the representative might have given us a pen or two when he came in, and they did fund some attendance at scientific meetings, but there was no other facilities or things that were funded by them.
In terms of DDAVP, we'll come on in a little while to precisely what categories of patients were treated and how, but the materials that we've looked at, the report that was sent to the Penrose inquiry, doesn't record DDAVP being used in the early 80s. How confident are you that it was used prior to, I think, 1984, which is the first reference, although with no quantities actually being specified?
I think it was used before 1984. I cannot, I cannot really say for definite whether it was used earlier than Dr. Han's arrival. I would be surprised if I hadn't discussed it with Dr. Willoughby, because obviously I had experience of using it, but I couldn't, say I definitely recall giving DDAVP. In fact, trying to recall giving DDAVP to individual patients after that period is difficult to recall. So I can't really say with any certainty. But as I say, because I had used it, I would be surprised if I hadn't discussed it with Dr. Willoughby or tried to use it.
Now, the treatment policy, the decision as to what kind of treatments to use and to use commercial products and so on, those are matters, as I understand your evidence to Penrose and to this inquiry, that were for Dr. Willoughby. You did not have any involvement in those decisions.
No,
So that's correct. You didn't have involvement.
I didn't have any involvement. I had no involvement, no.
When it came to the treatment of an individual patient, so a patient who would turn up as and when, as you described it, how would the decision be taken as to how to treat that patient? Would it depend upon what was in stock at any particular time? Did you have an involvement in that kind of individual decision?
First of all, I think it would depend on what the patient had received in the past, and it would depend on the age of the patient. And so I think we would probably try and use NHS concentrate when the patients attended hospital, but that might not always have been possible because we'd have to go over or phone over to the lab and get whatever was available. And obviously the younger patients and patients that may not have had received treatment before, we'd try and treat with Cryo Precipitate.
Now, the home treatment programme, which you've already alluded to, that was established by Dr. Willoughby prior to you taking up your role as a clinical assistant.
That's correct, yes.
Your written evidence to the Penrose inquiry suggested that when you started, you thought there were about 6 children on home treatment.
At least that number. It might have been slightly more. I can't give you an exact figure.
And over the next 2.5 years or so, again before the arrival of Dr. Han, did the numbers of patients on home treatment increase?
Well, I think they must have. I was trying to remember being involved in training, and in fact there was a witness statement to the Penrose inquiry that did who said that I was involved in training in 1981. So I must have been involved in training more patients for. I think the sister did most of the training, and then I would kind of supervise towards the end to make sure that everything was satisfactory.
And do you know how patients were selected for home treatment?
I think they were selected on the basis of, first of all, severity, frequency of bleeds, distance from the hospital. I mean, obviously, part of the rationale for home therapy is that any bleeding episode can be treated as soon as possible. And if patients were living further away from the hospital, that obviously would be an important factor. So that was severity, frequency of bleeds, frequency of attendance at hospital. I think those would be the main considerations.
What about age? Was there an expectation that when a patient with, say, severe haemophilia A got to a particular age, they'd be eligible for home treatment?
Yes, particularly if they were frequent attenders. I think Dr. Winters said it was age 3, and I think it was Professor Ludlam said age 4. I mean, basically, I think probably round about 3 would have been the age they'd be considered, but especially if they lived at some distance. And the worry was that, you know, if they lived at some distance and there was an acute bleed and an ambulance would call, sometimes an ambulance would only take the child to the nearest hospital, which could be the local district general hospital. So it was probably felt more important that these patients who lived at a distance were able to treat themselves, or the parents were able to treat the child immediately.
Were all the patients who were receiving home treatment patients with haemophilia A, or did you have haemophilia B patients on home treatment as well?
I think we had we had one patient with haemophilia B that was on home treatment, at least.
And in terms of the products used for the treatment of haemophilia B, was it, as far as you can recall, generally the PFC factor 9 that was used?
Yes, it would be the PFC. I don't think we used commercial concentrate at all. Well, I don't think we did at all.
Now, as you've already mentioned, the home treatment programme instituted at York Hill included prophylactic treatment.
Yes.
Do you, again, recall any discussion with Dr. Willoughby about why he took that approach, which may have been thought to be unusual for the time?
I think Dr. Hand described it as ahead of his time. Yes, yeah, I did ask him about the rationale for prophylactic treatment, and he said, well, you know, spontaneous hemarthrosis occur in patients who have who are severe haemophiliacs who have 1 or less % of factor VIII, and he felt that if, and I think he had looked at studies of prophylactic treatment, particularly in the United States, and he felt that if the boys were given regular factor VIII, I think it was either twice or 3 times weekly, it would be able to maintain their factor VIII levels at a low level, but at a level that might prevent spontaneous hemarthrosis. And one of his aims for introducing home therapy, apart from being able to treat immediately, reduce hospital visits, etc., was to try and prevent the dreadful crippling hemophilia arthropathy that those who were involved in haemophilia before the 80s, or even in the 80s, would be well aware of. I think Professor Ludlam gave a very good description of, the types of problems that this led to.
The effect, of course, of a prophylactic home treatment programme would be that patients were receiving significantly more by way of concentrate than they would if they were simply being treated as and when required.
Absolutely.
You've said in your statement that cryoprecipitate wasn't used for home treatment, wasn't regarded as practicable. Have you yourself ever had any direct experience of the use of cryoprecipitate for home treatment?
No, in fact, I haven't. And again, listening to the evidence that has been given by clinicians, I remember being quite surprised when I heard that it had, a way back in the early days, been used, I think, was it the Royal Free? Because I was always led to believe, and I think, again, from the evidence that you've heard, that it was generally felt that it wasn't suitable for home treatment for various reasons.
What was cryoprecipitate used for then at York Hill? We've seen the relatively modest amounts in terms of proportion that were used. When was it used?
Well, it was used for von Willebrand's patients, or patients with von Willebrand's. And I think in small babies where you didn't need to use such a large amount, it would be used in younger children. When I say younger, you're probably talking about maybe up to 2 years.
Is it fair to say that it was the combination of home treatment and prophylaxis that accounted for the majority of the concentrate use at York Hill in the early 80s?
I think it accounted for the majority, but I can't honestly say that patients who went on home treatment did not at some point receive commercial concentrate.
Your oral evidence to the Penrose inquiry discussed the length of time that could sometimes be taken for the SNBTS product to dissolve. What do you recall about that?
It just took a little longer. I mean, the commercial product dissolved really fairly quickly, but the SNBTS, you had to encourage it by gently. I think I described in the Royal, they had a roller system to help dissolve it, but in the York Hill we didn't, so you just gently had to swirl it around, as it were, to try and encourage it to dissolve. And I think that was recognised, again, in Chapter 1 of the final report of Penrose. There is talk about the difficulty of the product dissolving, and I think it was Dr. McClellan or Dr. Watt saying that they were working on this.
To what extent, as far as you're aware, was that a factor in Dr. Willoughby's decision-making?
Well, it wasn't a factor that he gave me. I noticed that in his statement he did say that the commercial product was easier to use because it did dissolve more quickly.
But that's not something he discussed with you? What, if any, discussions did you have with...
Before you go on to the next question, what sort of time are we talking about, the difference of time to dissolve the PFC concentrate compared to the time it took to dissolve the ARMA concentrate?
I think you're probably talking in terms of double the time, Sir Brian, perhaps, less than 5 minutes for the armour and maybe, 5 to 10 minutes for the NHS concentrate. But, that's trying to dig into my memory from many years ago, but it certainly was probably of that magnitude, maybe double the time.
Yeah.
And Dr. Pettigrew, just to remind you of your oral evidence to the Penrose inquiry, you said it could take up to about half an hour to dissolve the SNBTS product.
No, I don't think so. I don't know why I said that, unless there was some bottles that were particularly stubborn.
What, if any, discussions did you have, or what views were expressed to you by Dr. Willoughby on the question of the relative safety of commercial products and SNBTS products?
I don't think we ever had a discussion about that. And I don't think it was brought to my attention by him.
What was your own understanding?
I don't think it was brought to my attention by him, sorry.
What was your understanding, if any, in the early 1980s, your own understanding of the relative safety of commercial versus SNBTS products?
I think I was probably aware that the commercial product carried more risk, certainly, of hepatitis B, because of, I knew it was from paid donors, but that was really, I wasn't aware of pool sizes and things at that time because I never worked in blood transfusion. So, and also the fact that we didn't use it at the Royal Infirmary, I wondered if, apart from cost, I wondered if there was an increased risk from the commercial concentrate.
Now, I know of the World in Action documentary from 1975. Did you, as far as you can recall, see that at the time or ever have any discussion about it or its implications?
No, I didn't see it at the time. I was a house officer living in a little room off the ward in the surgical unit at the Western Infirmary at the time without it, and I didn't on every other night and no television. No, I didn't see it, and I don't think I saw it until it was shown in the process of this inquiry.
What was your understanding at the time of the relative safety of concentrates versus cryoprecipitate in terms of the risks of transmission of viruses?
I think it would, my knowledge at that time probably would have been limited to hepatitis B, and that the risk of hepatitis B would be greater with concentrate rather than cryo.
When you were involved with patients who were being trained for home treatment, what, if any, information was given to patients about the risks and the benefits and disadvantages of home treatment with commercial concentrates?
Well, I think it's been well expressed elsewhere that one of the prime concerns would be to prevent and also to treat bleeding episodes. When parents were being trained for home therapy, obviously they would be advised about the risk of hepatitis B, because we would give them instructions and advice on preventing transmission of infection, how to deal with blood spills. They were provided with gloves, aprons, what we called sin bins to discard any material in. So that that would be reinforced to them about the risk of hepatitis B and the prevention of the transmission of hepatitis B to family members. So they would be aware of hepatitis B. As I say, I wasn't really aware of the risks of non-A, non-B hepatitis at that time, and I think it was the body of opinion among haemophilia clinicians at that time was that it wasn't a serious condition. But, you know, as I say, I did start checking LFTs at the time, and when I was checking them, I would say that we're checking these liver tests because some patients with haemophilia have been found to have abnormal liver function tests on occasions, and we're not sure at that point what's causing it, and we're not sure if it is something, proteins or something in the concentrate, or whether it is, if there is another cause.
So in terms of information given to parents who were being trained for home treatment, you think the focus would have been on hepatitis B?
Yes.
Any discussion that you might have had more broadly about hepatitis would be limited to mentioning to patients who were being reviewed that they had elevated LFTs?
I don't think we ever had anybody with grossly elevated LFTs, just mentioning that we monitored LFTs.
As far as you can recall, were parents ever given a choice of treatment as between commercial concentrate, NHS concentrate or cryoprecipitate?
I don't know if that would have been discussed with them by Dr. Willoughby, but quite often, actually, in the early days, I think the parents in home therapy preferred the commercial concentrate because of what we've described. But I couldn't say that they were given a choice, no.
And when you say you think they may have preferred commercial concentrates, that's because of the convenience factors?
Absolutely, yes.
For those not on home treatment then, can I just ask you about the approach to treating patients at the hospital? Your statement to the Penrose inquiry suggested that very young children and mild haemophiliacs would be given or might be given cryoprecipitate. Is that your recollection?
That's my recollection, yes.
We've discussed DDAVP. To the best of your recollection, if DDAVP was used in the early 80s, for what categories of patients would it have been used?
Well, I think if it was used, it would be the patients who had mild haemophilia, or patients with von Willebrand's who perhaps required something like a dental extraction, or perhaps had a bleed that didn't require treated with concentrate. In other words, a bleed that wasn't felt to be a serious or potentially serious bleed.
And in terms of von Willebrand's patients, other than DDAVP, what treatment would they have received?
Probably cryo. I think we had one patient who had a severe form of von Willebrand's disease, and I'm not sure if I cannot recall if she always received cryo or whether she had concentrate at some point. So I cannot honestly say whether all patients always had cryo.
In relation to patients with moderate haemophilia, first of all, were there any patients with moderate haemophilia A who were on home treatment, to your recollection?
Well, I think there must have been, because when you see the figures, those dreadful figures of patients who were found to be infected with HIV, I think there was 2.
Yes.
Was moderate, am I right?
Yes.
Yeah. So there must have been patients with moderate haemophilia on home treatment. I think I can't remember patients with moderate haemophilia being started on home treatment when I was there, so they may have been commenced on home treatment before I came and transferred to the Royal before I came.
In terms of a patient presenting at the hospital who had moderate haemophilia A and required treatment, who wasn't on a home treatment programme, what would the approach have been to their treatment in hospital?
I think it would depend on what the nature of the bleeding episode was, and whether it was felt that it was a bleeding episode such as maybe a severe intramuscular bleed or a severe hemarthrosis that required to be treated with a a level of factor VIII that was known because there was a variability between the cryo and quickly. So I can't really say whether all patients with moderate haemophilia always receive cryo or they always receive concentrate.
And was there any system of batch dedication prior to the end of 84 or 1985 when there's some evidence of attempts to introduce it?
I certainly wasn't aware of any. In fact, I wasn't really aware of the concept of batch dedication, again, until watching the evidence that we've been listening to, that we've been given.
So I note the time. We
Yes.
started late, but it's now 11:30, so is this a convenient moment for a break?
Let's take a break now until 5 to 12. It gives you a chance to stretch your legs, have some refreshment. During any break, you will have heard me say this before to other witnesses, I'm sure. You're giving evidence. What you must not do is talk to anyone, whoever they are, whether at home or anyone else, about the evidence which you have given, or for that matter, about the evidence which you think you might be asked to give. You can talk about anything else you like.
Yes, thank you so much.
Look forward to seeing you at 5 to 12.
Okay, thank you very much. Thanks.